Let's call my dear friend Hamilton Zampoli. Yes, no, he is not doing it. Arthur can make it yet, but let's move on.
I'm here. If
He's
you,
going to talk about, well, he's General Secretary of CAO, the third largest urology association in the world. That's right?
That's perfect.
You, okay. So he's a friend. Even if he's younger than me, he's a mentor. And he helps me. So I truly appreciate that. So why you don't introduce yourself and tell us what is it that you're going to talk
We are all
about?
friends, so I think we all know each other. Oh, my fellow just pop up. Okay. So, can I give my slides, please? Can I have it? Eu creio que uma... Sí, sí, gracias. Bueno, I'm going to talk about why do we perform pelvic lymph node dissection in prostate cancer. Well, we play this kind of surgery because it's the gold standard for staging prostate cancer in high risk and intermediate risk diseases. And why is that? Because MRIs and CT scans, they're not reliable. We cannot, they doesn't have the actual accuracy that we were looking for. So we have the nodes, we can check it under the microscope. This is the perfect match, so we can see there's not. But that's not that simple. It depends on the surgeon to retrieve those nodes. It depends on the pathologist to find those nodes. That's why we divide those nodes like an extended pelvic lymph node dissection in levels 1, 2, and 3. And what is that for? For the pathologist to find out more nodes, and they do that. But according to data, it depends on the number of lymph nodes that you can retrieve. So pelvic lymph node dissection for staging, it's not that perfect. It's not bulletproof. So we cannot say that, wow, pelvic lymph node dissection is the best way to stage prostate cancer. So maybe there's an oncological benefit. And that's what we thought it would maybe help our patients to get less progression, less metastatic disease, and live much longer. But if we consider the evidence-based data that we have in 2026, there are 3 high-level quality studies that show us that is not absolutely true, this benefit. There's a systematic review and 2 randomized controlled trials. The systematic review was published in 2017, but more than 275,000 people included, and oncological benefit outcomes was evaluated in 29 of those studies, only 1 randomized controlled trial. And the answer is only for staging. There's no oncological benefit at all. That's exactly what we see in the randomized control trial. 2 trials, both the same, exactly the same design. This one is from our group in São Paulo. There was 300 patients randomized to limited versus extended pelvic lymph node dissection. Actually, we performed super extended lymph node dissection, levels 1, 2, 3, and 4, and 5. And the primary endpoint is biochemical recurrence-free. So you can see that there's absolutely no differences between those groups. And check the numbers of lymph nodes that we got. 12 lymph nodes in the limited group versus 41 lymph nodes in the other hand. No differences in early oncological benefit until more than 5 years. Okay, let's see the other one. This is from Memorial Sloan Kettering. It was conducted by my friend Corinne Touget. Same randomization. This is actual limited versus extended, levels 1, 2, and 3. More than 1,000 patients included, but check the numbers. 12 lymph nodes in the group of limited versus 14, 2 lymph nodes more. And in the group of limited, we got 11% of positive lymph nodes versus 13% in the group of extended. And absolutely no difference in the primary endpoint, which was the same, biochemical recurrence-free. No significant difference in the rate of biochemical recurrence. But Karim published it last year an update of this trial. And it showed us something special. Maybe there was a group that had a benefit in developing metastatic disease after 7 years of follow-up. Well, check those data. The biochemical recurrence-free, which is the primary endpoint of this study, is still the same. It's negative for both groups. The group that had this benefit was only the group that had actually PN1 diseases, okay? But look at that. The people that had negative disease didn't get any benefit. But let's see, which was the real benefit. At 10 years, 88% versus 85% of patients developing metastasis. So 3% difference in 10 years, but we are talking about 2 lymph nodes. There's nothing about possibly saying that it could be true in the history of oncological benefit in surgery. None of these patients got PSMA test. But let's see the main limitations of this update. This is not the primary endpoint, not even the secondary endpoints. It's a post-hoc retrospective analysis, so it cannot be interpreted as a randomized controlled trial. So it's not possible for us to say that this is a game changer, that this is the real world, and no, we proved that there's an oncological benefit. I'm sorry, but it's not true. And the problem is that how do they manage imaging these patients? Well, the oncologist decide what kind of imaging I would offer my patients, so it's not balanced. Another thing, there's an equal use of ADT alone versus ADT and radiation therapy adjuvant. So the patients that were worse got ADT plus radiation therapy. So it's different, okay? There's a very early recurrence for metastasis, which is not usual. Most patients had the development of metastasis during the first year, so it's quite, strange. As I said, 2 lymph nodes are unlikely to explain this outcome variation. Who performed extended versus limited? It depends on the surgeon choice. During surgery, surgeons decide, oh, this one I'm going to have limited, this one extended, based on what? On his choice. And definitely, it was a cluster randomization design. This is not a randomized trial. So I'm sorry, Corinne Touget, but this is not absolutely true. We cannot support this like a game changer in pelvic lymph node dissection. So, considering evidence base, we are not supposed to say that in 2026, pelvic lymph node dissection plays a role in oncological outcomes of these patients. But maybe there's no morbidity, so we can afford the risk. But actually, if we search the literature, there are almost between 2 and 60% of complications. In this review from Montorsi, you see intraoperative complications, bleeding, vessels injuries, obturator nerve injury in different levels, but up to 52% of patients. And most important, post-operative complications, lymphedema, symptomatic lymphocele up to 45% of the patients, and pulmonary embolism, 17%. It's unbelievable because it's something that can kill the patients. And DVT, 1 for each 4 or 4 patients. So when we look at the data for Scandinavian group, Peter Wickland, and he's trying to search only thrombotic complications in those patients. And look at this. This is comparing robotic versus open radical prostatectomy, absolutely known pelvic lymph node dissection versus some kind of lymph node dissection. The answer is that the group that get a lymph node dissection have 8-fold greater risk of deep venous thrombosis and 6-fold greater risk of pulmonary embolism. Potentially, that complication can lead patients to die. So, evidence-based in 2026, pelvic lymph node dissection, localized prostate cancer, does not offer 100% accuracy for staging. The oncological benefit is unclear, and there's a significant morbidity. So, do you think it would be worth only for staging if we got something like PSMA test? And you all know the PSMA test, which took patients with high-risk diseases. And what they found, that accuracy of PSMA PET showed almost 30% superiority comparing to CT scans, MRIs, and bone scans. There's a problem with this study. 23% of the patients didn't undergo any kind of lymph node dissection at all. So the sensitivity that is 85% in this study, maybe not that at that level. Actually, the majority of the studies published shows that sensitivity of the PSMA test is around 60%. But what we are looking for is for negative predicted value and specificity, which means the possibility of when you got a negative PSMA test, the patient doesn't have metastasis, which means negative predicted value. It depends on many things. It depends, the prostate cancer doesn't have the same expression of PSMA in the whole amount of the tumor, but the majority plays more than 20% of expression. As you see here, if the patient's got a temporary gene expression fusion, which is not that common, those patients that are ERG positive express less PSMA. But the majority of our patients doesn't have this mutation. But the most important things are PSA level and ISOP level. The highest number of ISOP and the higher PSMA level, the higher expression of PSMA. And there's something important. The expression in the primary tumor is not the same that is expressed in the lymph nodes. Look at that. You can see that in the primary, there's a very low expression of PSMA. In the same patient, we can see a higher expression in the lymph nodes. So you may check, and when you're looking, visualizing your PSMA test, you can see, well, this is the primary look. This spot, this segmentation express more PSMA. So let me check if the nodes or somewhere else there is expression of PSMA like that. But we are used to talk about PSMA always thinking about gallium-68. And this is not the only one that we should use, the most important trace used in PSMA test. Check this PSMA 1007. It has much more accuracy for any kind of prostate cancer. From ISUP 1 to ISUP 5, it plays absolutely outstanding outcome. And check those data. 98% of negative predicted value. That's what we're looking for. A negative PSMA test, it's a negative patient actually with his nodes. This is what I was telling you. Look at that. Here is PSMA 1007. You see expression in primary bilateral. When you got the gallium, only one side. You may say, wow, this may be the index lesion, if you believe in this concept of index lesion. But I want to know everything about my patient. So I want to know how much tumor he got. I don't care if it's a Gleason 6 or a Gleason 10. I just want to know, okay? And PSMA test using 1007 is fluoride is a nice option and cheaper and much more available than gallium-68. But important, Alberto Briganti published last year an update of his own nomogram, okay, and tried to validate among lots of other nomograms and validate the use of PSMA tests incorporated in those nomograms. And check out the performance of PSMA included in these nomograms is much, much higher than using a nomogram, Briganti nomogram from 2019. And that's what we saw in the European meeting 2 years ago, and Dr. Declan Murphy presented this real case. A 51-year-old guy with a PSA of 17, cribriform acinar adenoma Gleason 8, and a PIREDS 5. So with negative convention imaging and negative PSMA test. This guy, so this man is an organ-confined, high-risk disease, tested for germline mutation for DDR genes, which resulted negative. So if you apply the Briganti 2019, this gentleman has a 23% risk of lymph node involvement, so we must or we should perform a lymph node dissection. If the same patient, if you put those data in the updated nomogram, we can see that these patients had only 3% of lymph node positive, okay? This guy underwent a real pelvic lymph node dissection, 20 lymph nodes dissected, known positives, and he got to be reintervented due to a lymphocele. So, do you think that we should offer one procedure that's not good for oncological outcomes, that have a very potential outcome considering complications. For 97% that doesn't need to get this surgery. I don't think so. Actually, I don't. And actually, Dr. Strain from Netherlands published it last year. This paper is interesting because he was looking for many issues and benefits of lymph node or not, of PSMA test incorporated or not, of the weakness of oncological benefit considering our data available, and the answer is that for patients with negative preoperative PSMA test, extended pelvic lymph node should not be performed, even in high-risk disease. So in conclusion, I think that when PSMA test is negative, we should not perform a lymph node dissection. Primo non nocere, es decir, we cannot afford the risk of an important complication of seeing a patient dying of pulmonary embolism for 3% risk and no benefit, no oncological benefit. If PSMA PET is positive, what are we supposed to do? So we should consider that the patient should get the benefit of the doubt, and maybe we should perform a lymph node dissection. But if you want to be real, ethical, we should perform in a controlled trial, not among our patients. What we miss, well, I think the standardization of PSMA reports is very, very important, and they're trying to figure this out, like the pyrites score and something like that for PSMA, as well as quantitative PSMA tests. And fluoride is important because, as I mentioned before, it's a very more affordable, more available, and much better than gallium. And definitely, we are looking for more studies. The pre-PSMA trial is one of them. They're coming up soon. So thank you for your attention, and I hope I can help you if you have any kind of questions. Thank you.